Hello, I am Dizon, Chief of the Service Line in Hematology and Oncology at Tufts Medicine, and Professor of Medicine at Tufts University. And joining me is Susana Campos, Assistant Professor of Medicine at Harvard Medical School, and an Institute Physician for Dana-Farber Cancer Institute in Boston. And we are in Chicago at ASCO 25, and want to highlight abstracts in the Gynecologic Oncology section, and use that as a springboard to discuss how we might communicate these results in clinical practice. So, Susana,
yes.
What are you looking forward to?
I think this is an exciting year. I think there's going to be several abstracts that will get our attention. In the ovarian cancer arena, I think they're going to present the first trial, which was a trial that's an adaptive trial, that it really kind of came to light when Premia was still unknown. The results of Premia were still unknown. So they had an adaptive trial, and we're going to hear the results of either standard of chemotherapy, which includes a PARP inhibitor, versus that of standard of therapy plus dostarlimab. So those results are going to actually be presented, I believe, tomorrow.
Right, and Premia, just to remind everyone, was a chemotherapy trial that randomly assigned people to a maintenance treatment or after chemotherapy, right? And it was to placebo or niraparib, correct?
Exactly, and it was in the germline mutation positive. There was HRD, and it was all comers.
That's an interesting trial insofar as the use of immunotherapy really hasn't been very promising in ovarian cancer. What is your prediction?
I don't know. Well, we know from a press release that the progression-free survival is positive, but the question is how clinically positive is it at this point in time? And I think we'll also see B96 being presented also, which was also immunotherapy in recurrent ovarian cancer. And so we'll see what that has to say. Maybe a last hurrah for immunotherapy. We'll see.
It might be, but let's say it is positive, and this is interesting. You know, here at ASCO, when results are presented, they always talk about two things, right? They talk about clinical significant results and statistically significant results, one based on predefined metrics that the clinical trial is going to run in, which is statistical significance. But even if something meets that bar mathematically of being significant, we also look at the endpoint of the raw results, right? The medians, and say, are these clinically significant? So how do you approach that when you're looking at studies, and how do you communicate that when you talk to your patients?
I mean, I think that's a great question. Clearly, these studies have to be based on statistical analysis. And I think we have to be mindful of the fact and cognizant of the fact that these studies are done in a certain patient population, and we have to generalize these results to our patients at home, which may not always actually fit the same eligibility criteria. So, clearly we look to a progression-free survival, we look to an overall survival benefit, but we look exactly what are the numerical data, and how what does that mean to the patient? And that may mean different things to different patients. We may feel as physicians that this may not be clinically relevant, but to a patient it very well may. But we share that with them, and all the caveats that come with the clinical study also.
Yeah, I mean, I think that is that's the thrust of what we're talking about. I do recall many occasions where you sit in the audience and there's enthusiasm because something met the bar of being statistically significant. Say it prolonged the time before the cancer came back, or the progression-free survival, and everyone gets excited. And then it's days later when you actually look at that data, and you might say, it was only 6 weeks.
That's right.
Right? But to me, it doesn't look very promising. But to someone who's living with it, that 6 months, that 6 weeks might be really significant.
Maybe very significant. So it's important to distinguish that.
Yeah. And then the other thing, which I've started thinking about more, especially recently, is what is the endpoint that we should be communicating to people as being important? So we talk about progression-free survival, but there's a debate across medicine, really, that's not really survival. Survival's not based on being progression-free. It's really based on whether you're alive,
disease-free,
or no, alive or not alive.
Right.
So some people would like to use a nomenclature that actually we use in ovarian cancer, calling these intervals, like progression-free intervals. And I do think it's something that does confuse people. When you say, well, the progression-free survival is longer, And that's why I recommend it. And then I always get the questions like, well, it will help me live longer.
I know.
So how do you communicate that
And it's a
situation?
very good question, because I think there are different people on different sides. You know, clearly if there's a study that shows an overall survival benefit, we gravitate to that. Why wouldn't we? And communicating that to a patient and sitting before a patient and say, this is a study that they showed an overall survival benefit if this particular algorithm is actually is done. However, in the same breath, okay, the truth be told is we have to think to ourselves, what is overall survival? And what is that, you know, the end result of? Is that the end result of one trial, two trials? Is that the end result of comorbidities, where the patient may actually be treated, the advantages that an individual may have? So overall survival is contingent on many things, and it's not only contingent on one trial. I always remind myself, you're on a trial at the start of the trial, you're off of a trial at the end of the trial. Pre-trial is not randomized, post-trial is not randomized. So I think it's important that we understand these endpoints. They're both important endpoints, but I think it's also important to understand that overall survival is not contingent, but just one trial.
Right, and the debate I hear is when we're getting to more, you know, precise treatments, you know, that will block HER2, you know, with trastuzumab deruxtecan, or will block FOLR with mirvetuximab soravtansine, and the whole slew of antibody-drug conjugates and bispecific antibodies that are being rolled out. There's a theory that it's going to be impossible to see an overall survival advantage in trials because one will sequence through drugs, and you know, who knows, maybe the specific sequence might matter. But as for now, the relevant endpoint should be progression-free survival, because we can't control
it.
Post-progression and what people see.
Right.
Do you believe that?
I do. I actually do believe that. And we're going to be seeing the results of a particular study tomorrow that's going to be presented. It's the Rosella study, you know? And it's a very interesting study because it looks like at a completely different mechanism of action. It looks at cortisol modulation in platinum-resistant ovarian cancer. We're told that it not only did it meet its primary endpoint of progression-free survival, it also met its endpoint overall survival. So that's actually quite good. But it's introducing these new targets, these new mechanisms of actions to patients with platinum-resistant ovarian cancer, sensitive cancer, that really, at the end of the day, allow us to let women live longer with this particular disease. And that's an incredible thing to embrace.
Yeah, I mean, I think what I take from that is that it's not only important to increase the amount of drugs available to treat, but it does behoove us to be more careful. And you know, almost intentional about when we start and stop therapies. And I've actually been using more treatment breaks for if someone like sort of plateaus in a response, it's a little bit, you know, sick from the treatments, introducing that, you know, 6 to 8 week window where they just recover enough and then go to an ADC.
It's monumental.
Yeah, and you're able to do it now where with chemotherapy, progression was relentless. And you do a, you know, you do a treatment 2, you get a little bit of a benefit, and then it just starts growing again.
No, I think it's incredibly healthy for the individual to take a tiny little break when it's possible. When it's possible.
I guess in the last few minutes, why don't we just chat about, you know, all of these hinge on disease progression, all of these trials of when they become eligible, but also when we stop treatments, and then as someone moves forward. You know, I think there's a level of uncertainty that we as clinicians always have when someone is being treated for cancer, and it certainly is true in ovarian and endometrial cancers. But how we communicate worry is a really interesting thing that I've sort of started thinking about a little bit. You know, it might be that person who's, you know, had ovarian cancer, a known BRCA mutation, who, you know, did everything we wanted, did a HER2, chemotherapy, did a PARP inhibitor for 2 years, everything's fine. And then, you know, 7 years from the point you met her, 2 years after that PARP, there's something that's showing up. But you don't want to worry someone because, you know, at least for me, I always tell people we're doing this to cure you. And, you know, with each year that passes, the chances of cure are better. But then something happens. So how do you handle that when you might be worried, but the patient feels fine, you think you need a scan or you need to do some other intervention, refer to Gynecologic Oncology for a surgical opinion, but they are not aware of your worry?
No, I think it's very, very hard because how that interface is so important because you're not certain at that point in time. I do think that it really kind of emanates from the trust that you've built with that individual over the course of 5 or 7 years, whatever time that may be. And I think at first you have to be completely honest with them. You say, you know, this is a finding that we saw. It may or may not mean anything. It could be indeterminate. But we've always engaged in a certain way that we've treated you. We've always been proactive. Would you like to go down this pathway?
Yeah.
Okay, and I think you engage the person in that dialogue, you know, so that they feel confident in knowing the truth, first and foremost. That's absolutely the truth, but not to create, you know, a stir that causes tremendous distress. You know?
Well, you know, if I'm going to be honest, sometimes it's me.
Yes.
Who doesn't want to find that.
Yeah.
It's like, I cannot believe she's relapsing.
I know.
You know, let's just go bury our head in the sand for a little while longer and make everything fine. But then you have to tell someone that's your plan. And I think there's a difference. But when you're telling someone, I think everything's fine, but we should do a scan at some point. You know, let's do it in 3 months.
Right.
Because they might say, well, I was going to go visit my daughter. I was going to go to Europe. You know, I'm leading my second life.
Yeah.
I finally feel well. We're going on a 6-month cruise around the world. Can it wait? Versus telling someone, this might be a problem, this might be a recurrence, and we need to do a scan in 3 months. Because that situation, some people will say, why would you wait 3 months? If you think I'm relapsed, I want to know now.
Exactly.
Right?
Yeah.
So I think that's the balance that I always say, and it's hard not to interject your worry in the sense that you failed when someone is going through that.
No, and I think that, again, it's based, you get to know your patients. You know, there are individuals who will say to you, do the test yesterday if you need to, okay? And there are individuals who will say, no, I don't really want to do this, I'd like to wait a month, you know? And so the hope is that you learn this patient, and she learns you in terms of how to navigate a particular. So I don't think there's really a right answer to this. At the end of the day, we have to share with them with what we know, you know? But how we present it, I think, is extremely important, because we can cause chaos, and you know, the idea is that we shouldn't, and you know, unnecessarily so.
Yeah, and I think especially after 7 years, you know, someone who would come with their husband and daughter and son every visit, every chemotherapy treatment, in 7 years, most of the time they're coming by themselves because they feel so comfortable.
They are.
And they've been told everything's fine for so long.
Yes.
And they're just not prepared for that.
No, they're not.
So do you think there's I think you've answered the question, because you basically said there's no right or wrong on this. But in your opinion, as an institute physician at the venerable Dana-Farber, do you think there's a best practice?
I have learned, you know, I've thought about this over the course of many, many years, because what you do yesterday is not necessarily what you're going to do tomorrow. And I think the important thing is to understand who your patient is, because there are individuals who you can have a direct conversation with that desire a direct conversation. And there are other individuals who you cannot materialize. I mean, you always, you know, basically engage with the truth, but you have to be more gentle in your terms, you know. So I don't know that there's a best practice. I think we take care of many women with different backgrounds, okay? And I think we need to cater to them, okay? And I think that's the best way that I've learned over the course of the last years. You always worry about what you're going to say, and then you pray that when the words do come out, they are gentle, they are kind, and they are truthful at the end of the day.
I like that. I mean, and I think of people who are just starting in their practice in oncology, and if I, again, look back, I was fairly rigid. I was like, this is how you deliver this kind of news. This is how you discuss uncertainty. This is how you tell someone they've progressed. But it is with this, you know, almost maturation that comes with time as a clinician, that not only do you develop your style, right, but you realize you need to change that style based on that person.
Absolutely,
right?
Absolutely.
Yeah. And then I think the final thing, and I think the way you put it beautifully, I might actually have you restate it again as we end, you know, that you have to be truthful.
You have to be truthful.
You know, it's
but
like
you
whatever
have to be
you
kind.
feel. Yeah, whatever you
kind.
feel.
Yeah.
You have to be kind about it, but you also, it's not appropriate to tell them anything else, anything less.
Anything less is not appropriate.
Yeah.
But there's a way to deliver it, to be kind.
Okay.
Yeah.
Yeah, I agree.
Thank you.
Well, thank you for joining me and my friend, Susana Campos, And this is Don Dizon speaking from the 2025 ASCO annual meeting in Chicago.